All right, now you want to take us through, Dan, about the real fundamentals, the nitty-gritty of what constitutes this advanced monitoring we're talking about to help improve and standardize the care of our patients.
Yeah, thanks, Seenu. So, I think, thus far we've really tried to make the case that, this is an important thing for us to do. And I hope by this point, in the day and in kind of the conference that you're all with us on this. This is, being targeted, being physiologic, acting quickly, being protocolized. All of those things are really important. But now we're going to talk about the how. How do we do this in a way that makes sense? And what are the fundamentals of really this advanced monitoring that we're talking about? And what does that entail? What does it look like? How do we target physiology as we transition from a preoperative patient, a beating heart, a heart on bypass, coming off bypass, transitioning to the ICU, coming out of the ICU? What does that look like, and what is that continuum of care? So for the next few minutes, that's really what we're going to touch on. So we're going to start with the basics. I love physiology. I could talk about physiology all day. And when we really think about what it is that we're doing in the ICU, and this is why I kind of geek out and get excited about these ICU patients, is we have control of everything. We get to learn about anything we want to learn about these patients. And, as kind of baby interns, we learn that, okay, we're going to look at the blood pressure and the heart rate. We're going to start there. But really, there's a lot more that we can know, right? We can look at their physical exam. We can look at their urine output, kind of how much urine they're making per hour. We can now dial that in even further. We can look at kind of static pressures like a CVP, a PA pressure. We can look at cardiac function. We can look at their output, their index. We can look at tissue level oximetry. So we've got all these tools at our disposal that we can be using together in concert to really understand the patient. And if we understand the patient in front of us, then we can make evidence-based, kind of individualized, but protocolized decisions. And that's really what we're after here. So we can go to the next slide. So I believe, and I think the data is increasingly showing us that hemodynamic monitoring can aid our assessment of really this holy grail, which is tissue level oxygenation, right? When we think about what we're trying to do, yes, we want blood to move, but why? Well, we want the blood to move to carry that ever vital oxygen, the ATP, to the cells, so we can make ATP and nothing gets disturbed through these wild physiologic swings. So, with our hemodynamic monitoring, what we want to do is not only look at the pressure, okay, that's one way to look at the world, but we need to look at pressure, combine that with flow or output, and then also look at kind of resistance, the SVR, if you will, or the pulmonary vascular resistance, if we're thinking about the pulmonary bed. So that allows us to detect perturbations or problems really early. And then we can also dial in, our interventions with a lot of finesse here. So when we think about, this kind of goes back to one of those early physiology textbooks, but I think that those of us that do cardiac medicine with a good deal of frequency are thinking this in the background all the time. So really what we are always balancing is this mix between oxygen delivery on the one hand and oxygen consumption on the other. And as we troubleshoot in the ICU, really what we've got to do is optimize what we can optimize. Okay, we want to be adjusting what we can adjust. So, sometimes the heart rate's low. We've all seen that medical patient and we think, well, goodness, this patient's in shock because their heart rate's 35. Okay, that's really easy. I need to get a pacing wire in, or I need to, give them a medicine to increase their heart rate. And then all of a sudden things get better. Sometimes it's the stroke volume or the pump itself is not good. Okay, again, in the heart world, in the cardiac world, we see that all the time. These terrible hearts. How are we going to help that heart limp along? Can we give an inotrope? What can we do to support the heart? Sometimes it's bleeding or, the hemoglobin's low. Sometimes it's the actual oxygenation. We see, as a pulmonologist and kind of critical care trained doc, I see that all the time. So as we're thinking through this, we want to be figuring out where the problem is and kind of constantly adjusting our strategy here to try to improve, tissue level perfusion. Can move to the next slide. So again, kind of going back to 101 here, the determinants of cardiac output. Cardiac output equals heart rate times stroke volume, right? We learned that as medical students and, in nursing school early on. But really that kind of stroke volume, the ability to generate the optimal stroke volume is a lot goes into that. It's the preload. How full is the heart? It's the contractility. How well can it squeeze? Are there myocytes that work? And, what is the afterload, or that kind of the load on the heart when it tries to eject? And, when we kind of come back and think about this clinically, that's the physiology. Well, we know we're trying to target this, golden cardiac index of, above 2.5. If all of our patients had cardiac indices of greater than 2.5 coming out of the OR, Seenu would be a happy man. Like that's great. But we know that we're dealing with patients who live in this kind of chronic cardiogenic shock state sometimes. But, as we carry this physiology to the bedside, what does that look like? Well, in that row of red boxes down at the bottom there, you see, that preload is really the fluid and bleeding part of this. Okay. So even though I'm not saying preload all the time, I'm thinking, do they need more fluid? Is that really what I'm after here? And how do I know that if I'm making the decision to get fluid, how and why? Is it an afterload problem? Do I have vasoplegia? We see that a lot coming off pump, right? The vascular tone just isn't as good as we want it to be. Do we need to add pressors or do something else to get that vascular tone better? And then we also think about the contractility. Some of it's just the stunned heart, okay? Some of it is, we can look at the TEE intra-op and kind of understand that our heart is just a little sluggish coming off. And, that we understand that those are issues. So kind of all along the way, we want to be targeted with our physiology. And, I think this slide does a great job of, what we can do here is, yes, we can understand the physiology. We can also touch directly on pathobiology that we see in the ICU. Move to the next slide. So what is fluid responsiveness? Okay. And again, I think this is probably a 101 topic for most of us. But, for the longest time, and I made this, I'll call it a mistake, but I had this misconception, I think, as an intern. I would get a call on the phone. The nurse would say, hey, the patient's hypotensive. And my answer was always, give them 500 cc's of fluid and I'll be right there. And sometimes I got there, sometimes I didn't. And I gave patients buckets and buckets and buckets of fluid. And sometimes I'm pretty sure I weaponized that fluid. I turned that fluid into an absolute weapon. So I'd come by the next day and I've got 4+ pitting edema. And I'm like, you're going to have to explain this to someone on rounds, because what did I do? This is a challenge, I think that we've all done. And it's really about shifting a paradigm. I want to give fluid to the right patients, but I want to give fluid if they're fluid responsive. And really what we are looking at on this kind of Frank Starling curve here is that when I give my fluid, I want to see a change in the stroke volume, meaning I want that fluid to do something good for that heart, good for that perfusion, good for that blood pressure, and ultimately good for that tissue level perfusion. So, do you have any thoughts about this? I think this is kind of the dogma. Medicine and surgery has struggled with this, jointly over the years.
It's a great point, and I think you're exactly right. Another important concept is to understand that the fluid that you give, only a component of is going to stay intravascular depending on what patient type you're giving it to. As we mentioned earlier, some of our patients are malnourished, they're cachectic, they have poor tissue albumin levels already going into surgery. So you really hit the nail on the head is about fluid responsiveness. There's some patients, the fluid you give can either just immediately third space. There are others that have probably some inflammatory process. They're really not keeping it intravascular. And there are others that they have reached that endpoint on the Frank Starling curve where the fluid is no longer going to help them, but actually harm them. So
yeah, and it's a great point. And we've all seen that we've all seen that patient. I've done a bunch of pulmonary hypertension work, thinking about the RVs in particular, and fluid is a dangerous thing for a patient with a bad RV. You give too much and all of a sudden you're in big trouble. So, understanding where they are on this curve and kind of beginning to make up your own curve for this patient as you're caring for them really is where the art of this comes in. How are we going to do this? Well, there's a lot of different models out there. We're going to be kind of talking through one or a couple of different models for making decisions. But really, I think most of us are still going to begin with some sort of fluid challenge for the patient who is hypotensive or who is not, having, kind of the markers of perfusion that we would hope to see. And the reality is most patients, as they come off pump or come out of a cardiac surgery, are going to be a little bit dry, are going to be, intravascularly on the dry side. They're getting product back as they're rolling from the OR to the ICU. And so what we want to see, though, is that as we're giving this fluid, as we're giving the cell saver back, as we're transfusing product in some cases, that our markers of perfusion are improving. that our fluid status is changing, as we're giving fluid, that our stroke volume is improving. So what we're going to do is kind of continuously be testing and retesting this hypothesis. So as we give fluid, we should see on a patient who is monitored a stroke volume increase, okay? So the first is that we can give that fluid challenge, and we can see the stroke volume come up. Move to the next slide. So the other way that we can do this in a patient who, maybe you've already given a fair bit of fluid to, is we can use a passive leg raise. And, in our ICU, I will occasionally walk around and I will do just this. If a patient's still asleep on the ventilator, I will pick up their legs and lift them in the air and just give it, hold them there for 30, 45 seconds. And you can actually see it's like a bolus of fluid rushing from the venous system of the legs down into the heart. And in patients who are fluid responsive, you will see a very nice bump in the stroke volume. So very simple things that we can do, physiology 101 here, but it's nice that we can now begin to see that. That's something we've done for decades, but now we can see it in these unstable patients. We can see that stroke volume come up through our hemodynamic monitors.
And I think you're exactly right. You can see it in that continuous fashion, whereas before we would have had to shot a thermodilution before, then a thermodilution afterwards. Here you're kind of seeing it right there visually in front of your eyes.
Perfect. Yeah. Okay. So we're going to kind of assess fluid responsiveness with stroke volume variation. This is something that we can, begin to think about here. And so in the mechanically ventilated patient who's not breathing, all that spontaneously, we can look at the changes in the stroke volume, okay? And this isn't for every patient, but we did want to mention this. If you look at this variability across the ventilatory cycle, okay? If you're seeing these swings in the hemodynamics up and down, that should trigger your mind to think about, why is that occurring? Well, as intrathoracic pressures changed, okay, those intrathoracic pressures, go up and down, that impacts right ventricular, or really biventricular filling, okay? As the pressure goes up in the chest, there's less blood in the heart, okay? And as the pressure releases out of the chest, there's a little bit more filling, okay, that we can see in the heart. And so that stroke volume variation, if it's less than about 9%, the patient's unlikely to respond to additional fluids. However, if we're seeing a lot of variability in, with the respiratory cycle, then that patient's much more likely to be fluid responsive. So just wanted to throw that out there. That's not for all your patients, but I think we can use that in a subset who are still pretty deeply sedated with some reliability.
Hey, Dan, can you talk to a couple of maybe the loading conditions that need to be met in order to use SVV? I think that's a common area of concern of maybe overutilization of the parameter.
Yeah, so it's a great point. So, we've talked a lot about stroke volume, but really this variability, you need to have a patient who's either still paralyzed or very deeply sedated with a high sensitivity specificity. If the chest is open, that will impact things obviously as well. So you just want to make sure that you're using this on the right patient. Seenu, I don't know if you have other thoughts about that, about when to use this, or, red flags to watch out for, but those are the two that I think of most commonly.
I think you're exactly right. We're also kind of creeping into the world of hypotension, predictive indices, and things that are on the kind of cusp, and we can get into it at a later time. But really, that variation is important to track, and understanding that when you have great variations in stroke volume, that's your ideal patient. That is, and you really recognize them clinically by that's your roller coaster patient, right? That's the one that tends to transition from hypertensive to hypotensive. And the other example is, and I was going to tease you earlier when you said bleeding. I said, heart surgeons, we don't have any bleeding.
Right, there's never bleeding, right?
That's the other time that that my kind of hair on the back of my neck goes off, is when I see great variations in blood pressure, patients getting normotensive and then suddenly hypotensive. So in my mind, there are basically two things going on. It's either they're bleeding, right? This is an actively bleeding patient, then kind of bleeding and clotting, bleeding and clotting. And that's really what you're alluding to earlier. That's your physiologic demonstration of stroke volume variation, because every time you give those patients a little bit of fluid, they seem to look better for a brief period of time. And
and as the medical intensivist, that if your fluid bolus buys you 10 minutes to walk away from the patient, and then you get called right back, these are the things that